Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hotzel. I'm your host of the show, and I want to welcome all of you, whether you're live on the show or whether you are watching this on replay. There's quite a few people always watching this on replay as well. So before we go into today's questions and answers, I can already see there's questions in the chat pad. So thank you, Tracy, for posting them here. If you like my work, subscribe to my YouTube channel, click the like button and the notification bell, and share this video with your friends and families, of course, and always comment below what you want to see next, what questions and insights you have, so I can obviously make the right content for you. So before we go into today's questions, what makes me qualified to answer questions for families in intensive care and intensive care at home? Once again, my name is Patrick Hotzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse unit manager in critical care, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com, and I can very confidently say that we have saved many lives for our clients and members when they have a loved one in intensive care, and you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast section, where we've done client interviews. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we're sending our critical care nurses into the home predominantly for long-term ventilated adults and children with tracheostomies, but also home TPN, home BiPAP, home CPAP without tracheostomy, and tracheostomy without ventilation. We're also providing port management, Hickman's line management, central line management, and PICC line management at home. We're also providing ventilation, weaning at home, IV antibiotics, IV fluids, palliative care at home. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, and DVA all around the country. And also we have received funding through public hospitals, private health funds, as well as departments of health. We're also providing level 2 and level 3 NDIS support coordination, and we're also providing TAC and WorkSafe case management in Victoria. Without further ado, we will be going for about an hour. I will wrap this up in about an hour. So if you want to talk to me, type your questions into the chat pad, or even better, you can connect with me here live on the show on StreamYard. I've just posted the link in there, so you can just click on that link, and then I'll get you in as soon as I've answered Tracy's question. So Tracy, you are writing, "Good evening, Patrick. My dad has been in ICU for over 3 weeks after attending accident and emergency, which is ED or ER. As he couldn't breathe, he was taken to resus as his SATs was 50% oxygen on arrival. The next day he was in an induced coma." Wow. Okay. In ICU, he successfully came out after 42 hours, then put back into another induced coma 32 hours later due to blood oxygen. His diagnosis was ILD with severe pneumonia. I was told he was making progress. Then you are saying pneumonia was clear, and inhalers to manage his ILD. As soon as his oxygen levels were safe for the ward, that would be his next step. However, for 2 weeks now, they have been unable to remove the high-flow nasal prongs. Okay. Oxygen via the ECMO machine is steeped from 40% of oxygen to 82% SATs to 70% oxygen with 92% SATs. He's been checked for everything. He's infection-free, but still needs so much oxygen, steroids. Right. Then have been given via a drip for 3 days. And Dad has been told, and I assume you are referring to steroids here, have been given via a drip for 3 days, and Dad has been told if they don't work, he's going to start deteriorating, and they will start end-of-life treatment to make him more comfortable. He's made no improvement today. He's been moved from ICU to ED ICU. My question is if Dad's still eating and drinking, reading, talking fully awake and aware, is end-of-life his only option? And would it be possible for him to have end-of-life care at home with him needing so much oxygen? He has been told so many different things that this isn't the ending we all were expecting. Thank you. All right. Tracy, let's just clarify some terminology here also for our viewers. ILD is interstitial lung disease. It's also known as lung fibrosis. Now, the first question that I have, Tracy, is your dad on ECMO? It sounds to me like he was on ECMO, but is he still on ECMO? And I kind of doubt that he's still on ECMO if he's been moved out of ICU into what sounds to me like a step-down ICU or a HDU. Can you please clarify if your dad is still on ECMO? That would be the first thing. Because if he still is on ECMO, he might be awake. The ECMO might be taking over the function of the lungs and he might be perfectly awake, right? So, 2 questions here, Tracy. Is your dad on ECMO? What's your dad's age? How old is your dad? Just hang on, there's Leanne, high flow oxygen, sister here. Okay, I see. Okay, not on ECMO. Okay, so let me ask you this, and I say it with a smile on my face. You know, your dad is eating, drinking, talking, reading. Does that sound like someone who's dying? With everything that you've shared with me here, it doesn't sound like you are talking about a person that's dying. Your dad is 66. Okay. So what is important in a situation like this is you have to watch what is actually happening, not so much what people are saying. The intensive care team potentially is trying to create a narrative of end of life. Okay? Well, your dad's talking to you, he's eating, he's drinking, he's reading. Doesn't sound to me like that's someone who's dying. Now, that will probably not stop the intensive care team from creating a narrative about end of life, because that is in their interest, right? They don't want to put any more resources in your dad, which is why they're starting the narrative about end of life. Simple as that, right? So, how much oxygen does he need? Let's just dig down a little bit deeper. So he's on the high flow nasal bronchs. How much oxygen does he need? How much flow is he on? And also, how many days has he been off ECMO? Right? Those are questions that are all important. He's fully awake. He's 66. So does that sound like someone who's dying, Tracy? I know what it looks like if people are dying. I've seen plenty of people dying in ICU with intensive care at home as well. You're not telling me a person who's dying. Am I wrong here? You are believing the narrative that they are giving you. 60 to 75% on 35 flow. Okay, that's a fair bit. Okay, yeah, no, that's a fair amount. What's his oxygen saturation like? And also, Tracy and Leanne, don't be shy in coming onto the call here. If you want to talk to me, just click on that link. Don't be shy, I don't bite. I do believe your questions can be answered so much quicker if you come on the call here. Right? Your questions will be answered so much quicker. Just click on that link and talk to me. So, this isn't it. What's his oxygen saturation? And also, he's still on the steroid drip, okay? And then the other thing is, it's 92, okay? All right, okay. So, a few other things here. Interstitial lung disease, also known as lung fibrosis. Now, the challenge you have with interstitial lung disease is basically means it's scar tissue and inflammation on the lungs, right? That means the lungs are really stiff and they lack compliance. You know, when we're breathing in, the lungs are elastic, and that's one of the reasons why there's gas exchange happening, oxygen in, carbon dioxide out. Now, if there's interstitial lung disease and there's inflammation and scarring, it means the lungs are no longer elastic and the lungs are what's called resistant, okay? He's had his last drip today. What do you mean with last drip? Last drip of what? Last drip of steroids? Please be specific. So, obviously he's come off the ECMO, right? How long ago did he come off ECMO? That would be really important to know. How long ago did he come off ECMO? Going to tap. Okay, Leanne, hang on. Hi, Leanne. How are you?
Hi. Okay.
That's good. Thank you. Thank you for joining, because I think that's the quickest way we can map out any questions
definitely.
that you have. So, Leanne, how many days has your dad been off ECMO for?
He was on in induced coma he was in induced coma for 2 days, out for 12 hours, breathing by himself. Then he went back on for 2 more days and has been out for 23 days on high flow oxygen.
Okay.
It's up and down all the time.
Right.
On the slightest, like he only has to, well, before the steroids in the previous 20 days, 21 days, it's like when he coughs, speaks, eats, his saturations drop.
Okay. Now that paints a better picture. How long ago was the ECMO removed? How many days?
23.
23 days ago, or on the 23rd of January?
23 days ago.
23 days ago. Okay. How many days was he on ECMO?
He was on for 2. Is ECMO
2
the
days?
same? Is ECMO the same as induced coma?
No.
ECMO.
No,
he hasn't been on ECMO then.
Okay. But ECMO would have been discussed?
I haven't heard of any ECMO. He did have a thing in his neck, like just to take blood or something or other that had little things on. But other than the ventilator and the induced coma, that's the only other things I know he's been on.
Okay. Oh no, because in one of your messages you say oxygen via the ECMO machine, he's dipped from 40. You were talking
by the I think that's she's giving you the precise name of the actual machine that produces the high flow.
Okay, that's okay. Now, is this diagnosis, the interstitial lung disease, is that a new diagnosis, or did you know about that before this admission?
It's a new diagnosis, but they said he should have been diagnosed with it back in 2021.
Okay.
It's a misdiagnosis or something.
Right. Okay. Did your dad have COVID?
No.
Okay. All right. So, okay. And now...
he was, sorry to interrupt you, he was working up until 3 days before he went in. He was a builder on a building site. He always had a really good lifestyle, ate healthy, doesn't smoke. It was a real shock. So
this comes out of nowhere.
Wow.
Wow.
Plus, he also forgot to mention he's had a consistent cough for over 2 years.
Okay. If he's a builder, is he potentially exposed to asbestos?
Yeah, they did mention that. And they also mentioned they've talked to 2 specialists. One's thinks it's idiopathic fibrosis, pulmonary fibrosis.
Idiopathic,
Yeah.
pretty much the same then.
Yeah, and another specialist has said they don't think it's that. They think it's inflammatory. Yeah.
An inflammatory disorder or.
But he said he's had every test. He's been tested for pneumonia, fungal, HIV, viral, and all of them have come back clear, negative.
Okay. So, Leanne, the question that I have is, do you think he's dying? What's your impression?
No.
Do you think he's dying?
No, I just think he's finding it hard to breathe.
Of course. So he's eating, he's drinking, he's talking.
Yeah.
He is reading. You mentioned he's reading.
Yeah.
Right.
He's sitting out of bed
Sitting out of bed, that would have been my next question.
Yeah.
Okay. And he's doing all of that on 60 to 75% of oxygen on the high flow.
Yeah, but when he does do any activity like that, except for reading, obviously, his sats do drop, and they do have to come over and hire everything up. But they'll stand there with him for a minute, and then they'll lower it all back down, or leave him like that for a bit.
Okay.
And then come and lower it.
Right.
When he's back to where they want him to be, type of thing.
Right. Okay. So getting out of bed is obviously exhausting him. He's getting short of breath, but then he recovers.
Yeah.
Okay. Now, have they mentioned in any of these a lung transplant?
I asked him today about a lung transplant, and he said that's not an option for your dad because your dad's not well enough. So when he said that, I said, I watched a video of yours, and you talked about predicted end of life and real end of life. So we asked him that question. I said, is this a real end of life or a perceived end of life? And he said, well, I'm just at the top of the road here, and I don't know which way to turn down.
Okay. Who did you ask that question to? Who's the primary physician at the moment that's sort of in charge of his care?
It's just like one of the doctors on the ICU.
So, okay, it's still ICU making decisions.
I think they have spoke to specialists.
Okay.
I can find that out.
Okay. Whereabouts are you? Are you in Manchester, Liverpool?
Liverpool.
And
he's at Aintree Hospital.
Yeah. Look, I used to work in Liverpool long time. Liverpool and Manchester, long time ago.
Wow, what the chances?
I used to do some work at the Children's Hospital in Liverpool in ICU at Alder Hey.
Alder Hey, yeah.
Anyway. So look, I do believe the discussion around a lung transplant needs to be had, right? Mm-hmm. So obviously they want to talk about end of life. Mm-hmm. I think you need to bring this discussion back to a lung transplant. You're asking in one of your questions, can he have end of life at home with that high level of oxygen? Yes, he could. However, I can tell you there would be patients at home on high flow nasal prongs waiting for a lung transplant in a similar condition.
Yeah.
Right? So therefore, I do believe the question of a lung transplant needs to be brought up. Right? Yeah. Now, I don't exactly know what the cutoff is in the NHS. There might be a cutoff for a particular age.
He did mention they don't offer it to patients on ICU. It has to be like an outpatient at home or.
Right. Is your what's your dad on at the moment? He's got the high flow nasal prongs. He's got the steroids. Do you know if he is using BiPAP on and off? Do you know what I mean by that?
I know what you mean now. He's just
BiPAP, like
the,
when they take the face mask off, when they take the high flow off, do they put him on a mask?
They put him on a mask, but it's just the one on the strings at the sides. It's not like the very tight one that's like very fit. He did go on that one for a little bit, if that's the one that you mean. But when he swaps over now, when he had to like blow his nose, and that was uncomfortable, so he put this one on for a bit. But it just had like two skinny green strings here.
Okay. Right. Okay. And how long is he using that for?
Not long, because he does find the other one better, like because he can speak, eat.
Yeah. And if he is using that one, if he's using the mask, is his saturation coming up?
His saturation's okay with that one, yeah.
But is it going higher than 92?
I haven't noticed. Is
Would
that
be
something to look
interesting to
out
know.
for? Yeah. Okay.
Definitely something to look out for. Or is it even dipping? But I don't think it's dipping. How often is he using that?
Would you suggest that one's better to use?
It's probably more uncomfortable. You've already identified that it's more uncomfortable. Is that
The nasal one is most probably the one I would have thought was more uncomfortable, but
okay?
he prefers the nasal one because he can eat and speak.
Of course. So
But if
the
it was for go on.
The mask, is that attached to a ventilator?
Yeah.
Yeah. Okay.
Yeah.
So it's not a case of which one do I prefer. It's a case of which one does he need, right? And I would argue that when they put him on the mask, I would think that his oxygen saturation is actually going up.
Yeah.
Right? Now, the BiPAP would be more uncomfortable, no question, but also more effective. Right?
Yeah.
And yes, he couldn't eat and drink, of course. But that's also one of the reasons I have been wondering, why is your dad still in ICU if he's on the high flow nasal prongs? Because they might be able to manage that on the ward. However, now that I know he's also on the BiPAP on and off, that also makes sense to me, that why he's still in ICU.
Yeah, they said he wouldn't be able to go on a ward with this much oxygen.
Yeah, I'm not surprised. Look,
Yeah.
some hospitals have respiratory wards that can manage the high flow nasal prongs, even on high levels of oxygen. However, now that I know he's also on the BiPAP or the CPAP, that would definitely prohibit him from going to the ward. Right? Now, Tracy's saying here, Tracy is your sister, Leanne, is that right?
Yeah.
So your sister is saying it's like they have all given up on him. Now they say the steroids are the last, and if they don't work, there's nothing else they can do. It would be end of life, and they're not working. Does your dad have an advanced care plan?
What's that?
So an advanced care plan is basically, anyone can have an advanced care plan, basically saying something along the lines of, hey, if I'm ever in a situation like this, I want everything to be done. If I'm in a situation like this, I don't want everything to be done. I just want to die comfortably, whatever. This is about expressing your wishes for medical treatment or lack thereof.
Yeah. Well, my dad told me today that he wants to live. He doesn't want to die.
Yeah. Okay. Has he expressed that to them?
I'm not too sure.
I think it's important that he does. I think it's very important that he does.
Okay.
That's number one. Number two, but this is not documented somewhere in an advanced care plan, in a living document. It's not.
Okay.
It's not documented.
I'm not too sure, but I'll check that out tomorrow for sure.
I would. And if it's not documented, I would recommend that you do, or that your dad does.
Definitely.
Okay.
Okay.
So now that I understand more about your dad's situation, a couple of more questions. Do you know his heart is working fine? There's no issues with heart?
They did mention something about right heart thickening.
Yeah, which would tie in
Well,
with
yeah,
the ILD. It would
Yeah.
tie right in with the ILD.
where it's been working so hard to cause the lungs and stuff, yeah.
Okay. Do you know whether he's on medication for the right heart?
They haven't mentioned anything. The only medication that he's been on is the steroids.
Steroids. What about nebulizers? Is he on
Yeah,
nebulizers?
he did have a nebulizer, yeah. Yeah, you're
Okay.
right, yeah.
Regularly?
I think so. I think the giving them like for a couple of nights, maybe a week or 4 nights.
Okay. All right. Just to refresh my memory, when he was intubated, how many days was he intubated? Just for a few days, 4 or 5 days?
Yeah, 2 days on, off for 12 hours, and then 2 days back on.
Okay, all right. So that's not too bad at all. I mean, in the bigger scheme of things, that they could get him off the ventilator quickly. That's not too bad at all. Do you know if he is on inotropes or vasopressors for a low blood pressure? Do you know whether he's got a low blood pressure?
He has high blood pressure.
It's high blood pressure. Okay, good. Okay, good. Well, not good, but that's better actually than low blood pressure.
And low blood pressure.
Yeah, no, okay, that's good. Kidneys are working.
Yeah.
Kidneys are working. Is he in pain?
No.
Okay, not in pain. Liver's working. No talks about liver not working.
No. Nothing.
All right. Okay. So the way forward here is that I can see is I do believe you need to start advocating for a lung transplant. Like I said, there would be some rules within the NHS. The cutoff for a lung transplant might be 65, but I'm a big believer that everything is negotiable in life. It also sounds to me like right up until this happened, your dad was fit and healthy.
Definitely.
It was working.
Yeah, working, going on holiday, walking up mountains. Ate healthy, didn't smoke.
And then
Didn't
this
smoke.
hits him out of nowhere.
Yeah. The only thing he's had was that cough, which he'd been going to doctors for, just getting, no answers.
Yeah.
Ongoing.
Right. Did they do an X-ray, chest X-ray leading up to this hospital admission?
He went for one like I'd say maybe 2 weeks prior to the admission.
2 weeks prior, but not the family doctor that was looking after the cough did not think of doing an X-ray.
No.
Okay, because this could have potentially been sussed out earlier.
Yeah, definitely, yeah. Something that was, if caught earlier, could have been prevented.
Yeah. Okay. Look, they obviously want to talk about end of life, right? Where I see this going towards a lung transplant. I think you need to start advocating for that. Do you think your dad is open to that?
Yeah, definitely, if he wants to live. Yeah.
I think the conversation needs to be moved towards that. They're not giving him any sedation, any morphine, anything that's sort of helping him with comfort. There is no discomfort besides the breathing, is from what I'm hearing.
Yeah.
Okay.
Yeah, they're not giving him nothing. The only thing he's on is the steroids.
Right. Okay. What about DNR? Do you know what I mean with DNR?
My sister mentioned that to me tonight, so we're going to see about that tomorrow.
Okay. What are they saying about that?
I don't know. Is Tracy saying anything? I can't see nothing right now. Let's say chat.
Tracy hasn't said anything there, but it would be good to get an idea about what's happening with DNR. And Tracy can come on the call here too if she wants to. Just use the same link. because what I can see in a situation like that, Leanne, is that they might want to push for a DNR.
Would they have
Which-
to ask me dad for that, or like get someone's permission for that?
Unfortunately not. In the UK, the NHS can pretty much do whatever they want. However, it comes back to what I said before. I do believe you need to push back very hard. You need to push back very hard on this, especially since your dad is awake and can make his own decisions.
Yeah.
Right? The UK is the only country, the only health system in English-speaking countries where they can pretty much just issue DNRs whichever way they see fit. Wrong on all ends, as far as I'm concerned. It's wrong on all ends.
Definitely.
You know, and I think you need to push back very hard there. And your dad needs to be the decision maker here.
Yeah.
Not the NHS.
Yeah, definitely.
Because one thing that happens after a DNR is potentially issued, I do believe it's half of the death sentence. You know, sort of people are saying, oh yeah, this person is DNR, let's just wind everything down.
Yeah.
Right? And just to prepare you for what they will say to you, they will tell you that resuscitating a patient can fracture ribs.
Cause more damage.
And that is true.
But he's already gone. In that situation, what more harm could you do?
What more harm could you do?
Yeah, exactly.
Right?
Totally.
You know, so just be prepared. That is what they're going to tell you. They say resuscitating someone is cruel. Right? Instead of looking at it, well, it saves someone's life. You know, or at least it has the potential to save someone's life.
Yeah.
Right? Tracy's saying that telling dad he's going to deteriorate if the steroids don't work. He's even giving himself till Sunday, as that's what the doctors keep saying. Look, you know, nobody knows whether the steroids might be kicking in tomorrow. The ICUs are always working with timelines, you know, with artificial timelines that they give themselves and saying, well, if it's not working by Sunday, you know, then from that point onwards, we'll only talk about end of life.
Yeah.
You know, I do believe you need to move that conversation away to from end of life and towards a lung transplant. Right. Got Tracy here now as well. Hi, Tracy.
Hi.
Did you want anything to add here?
Yeah, the DNR, it's got to the point where when I've tried to mention the DNR, even though it didn't want to be mentioned, it has to be an option to be explored. They've made me think that even a DNR wouldn't be advisable because they don't even put me dad off even getting another option to be ventilated again. Like 2 doctors, I've been in the presence of 2 different doctors saying you won't survive another ventilation. Even if you do come out of another ventilation, your lungs are too weak. You'll still be in the same position you are in now, and we will be unable to help you. At the same time, we are only allowed on the ward 1 till 7. There's doctors that are coming round when we're absent. We come into dad, and dad's like, they've told me that's it. They've told me that's it. They told me, I'm not, if this doesn't kick in, it's not working. We don't know what he's getting told when we're not there. And it's been 3 weeks now, Patrick, and he's had these nasals up his nose. He's getting tired. As the doctor said today, it's like he's got his head out the car window. I do feel like ventilation would be an option if it come to it. And that's why they're trying to change dad's mind to not be an option, to the point where they're saying to dad, why didn't you like the ventilation? What didn't you like about it?
Yeah.
And I can see dad thinking
putting them off it.
Putting them off it. So it's not even an option to get it again. but I know they have to do that. They are trying to put things in place now to say, no, you didn't want that, or, you know, if he does deteriorate. But now he's actually given himself till Sunday, Patrick. If these steroids don't work by Sunday, that's it. You know, I mean, lungs are gone.
That's sort of what they're also putting in his head, especially when you're not there.
Yeah,
Wow.
definitely.
Yeah.
Would you agree, Leanne?
Yeah.
So psychologically, they're putting him in a very dark place just by
Yeah.
talking to him,
Yeah.
giving him the doom and gloom.
Yeah.
Mhm.
And the tough thing is as well, Patrick, is that 2 days prior, he had different doctors saying, once these steroids to kick in, you know, you'll be all right. And he's going, well, when will he kick in? When will I be able to breathe again? And they're like, well, they're going to kick in. 2 days prior to that, we're going to go home on the
Inhalers.
2 days before that. So it's been a real roller coaster over the past few weeks. It's not, you know, and now it's got to gloom and doom so quickly.
Yeah. Okay. So the issue, I tell you what the issue is with interstitial lung disease. If he does need to go back on the ventilator, it will be difficult to come off it because there's scar tissue on the lungs and they're really stiff now, right? So it is going to be difficult to get off the ventilator if, God forbid, he needs to go back on it. That part I agree with the doctors. But if you look at the patient population that are on lung transplant lists, now I don't have the exact figures, but a lot of those patients would be interstitial lung disease or which is also known as fibrosis, right? So your dad, as far as I can see, fits the criteria that many other patients fit when they are being put on a lung transplant list, right? Now, what rules out a patient going on a lung transplant list, from my experience, is if people are no longer walking, talking, mobilizing, you know, they're completely bedbound. Now, once again, that is not the case in your dad's situation. He's still getting out of bed every day, from what I'm understanding. You know, he's eating, drinking, he's got his brains about him, right? He can make his own decisions. So that, as far as I can see, is similar to most other patients that would be waiting for a lung transplant, right?
Mm-hmm.
So timing here is of essence.
Sorry, Patrick, can I just interrupt you? The last two, last night, they made the decision to move Dad to this lower ward. And since he's moved, he hasn't got out of bed today. He never got out of bed yesterday. And it's like, so even though he was doing all that the last couple of days, it's like, these steroids aren't going to work. Let's stop everything now. But, you know, we're not even getting you out of bed.
So Patrick's saying to push for the lung transplant.
Yeah.
I do believe that is the only way forward. Can he go home on high flow nasal bronchs? Yes, he can, even on 60-70% of oxygen. However, you know, he would probably need 24-hour nursing care, you know, and you would need someone that can pull that off in Liverpool. I'm not sure whether there is someone. It's definitely possible. I mean, you know, I don't know how much research you've done. We are looking after ventilated patients at home with tracheostomies, ventilation. You know, we're doing that at home in Australia, here, Melbourne, Sydney, Brisbane, right? It's definitely possible. Your dad could go home on high flow nasal bronchs, but you need a service that can pull that off.
Control it, yeah.
Right. When you say he's moved from ICU, where did he move to like a step down ICU, like a HDU, high dependency?
It's like a step down. It's like where they put patients that are waiting to go onto the ICU ward, or waiting to go onto another intensive ward. Like, but at the same time, I know on the internet, I've done a research, and it says they tend to put patients here. What was the word, Leanne?
It's not palliative care, is it? It's not a palliative care.
Well, like type of thing. She's most probably gone to look now what it was called. Dumping ground.
Dumping ground.
Yeah. Known as this is what word she's when she's put it in the thing, it's known as the ICU dumping ground. Basically, patients who are terminally ill at the end of life, or palliative care, or
So who's using that? Who's using that term? ICU dumping ground. That's terrible. Who would be using?
Well, that's what's given us the fright today. There was a letter up on Dad's board today for when the nurses come in, and even to the point where in the ICU ward, he has a board and he says, Tommy, and it says, what's your dad's what is it, Leanne?
Get back to the
Yeah.
dumping ground thing. What you were telling them. You researched this because he'd been moved to a different ward. We were like, why is it being moved? They told us because he was getting disturbed by a man overfacing. That had been brought in with the police. They were disturbing him. So when we asked Dad was like, oh no, it was a little bit of entertainment for me. And then when we went today and we went to get into the way we usually get in, he said, oh, he's been moved round here because it's a little bit more private for him round here. Just don't know. And then you see my sister researched it, like, what does this mean when they move to this type of ward? And that's what.
Yeah, because I questioned it. I thought if there was a patient on the ICU ward that was making such a noise, then why didn't that patient get moved? It didn't make sense to me that why they'd move my father and not the patient.
Not all the other patients. Why weren't he disturbing everyone else, type of thing?
But then my dad said the nurse had a chat with the other nurse, and then the other nurse come back and went, I think it's best we move you because your family won't be happy if you don't get enough sleep. So they moved him to this little corridor where, like, patients are waiting to get on the ICU ward, patients are too sick to go down to the ward, and patients end of life, basically. Just basically that term what I've just said to you. Dumping ground.
And this is like an official term, dumping ground, or is this like an informal term they're using there?
No,
I'm not too sure.
I've seen the word on the board and then I've researched it and then when I've researched it, it's an EDICU, and an EDICU is where patients go who are waiting to go on into the ICU ward or into another important ward. The too sick go down to a normal ward, but at the same time, it's getting used as a dumping ground for end of life care.
That is absolutely shocking to even use such a term.
No, it's vile, isn't it? Disgusting.
Unbelievable. Okay, so, and this happened today, Saturday.
Last night he got.
Last night.
Yeah.
Did you know that they were planning to do this?
No.
It just comes out of nowhere.
Sorry, Patrick, they've done it dead, like, not sneaky, but if he was to get moved, couldn't it, go through us? They said, oh, we're moving you because of this other patient, and my dad's gone, no, I'm all right, I'm quite happy, yeah, and then
bit of entertainment.
Back over and gone, no, your family's not going to be happy. So he'd like used, and then he's thought, oh, because we're being quite protective of him right now. He thought, I don't want my family upset, I'll move. So he's moved.
Oh my goodness.
Yeah.
It's just absolutely shocking what I'm hearing here. Just absolutely shocking. I, especially in light of the fact that they have now moved him and, sort of trying to hone down on that narrative about end of life and whatnot.
Yeah.
I think you need to act pretty swiftly here and start talking about the lung transplant instead.
Yeah, and get the DNR in place.
Well, I would not get the DNR in place. I would not.
Taking out of place, is it? Taking out of place, I mean, yeah. Sorry, the other way around. Definitely the other way around.
Yeah, the DNR is, if anything was to happen to Dad, they'll resuscitate him and bring him back to life. So they put that in place, and then
we don't want that in place, yeah. Yeah, sorry, I got confused.
Don't want that in place.
Definitely don't want that in place. I got confused.
Do they? And given what you're telling me here, I'm concerned that it might already be in place. I'm very concerned about that.
So am I. I wanted to mention that today, but we thought we had high hopes that these steroids would kick in. That was, and the whole family. It was like, don't talk about that today.
Yeah.
Talking about that. Let the steroids kick in. and it was like I felt like I was uncomfortable to talk about that because I was upsetting the family a bit more.
Okay.
Yeah, but not if you're saying we don't want that in place.
It was
Moving
just
towards,
talk about Dad.
yeah.
These steroids don't kick in. I am having a word with Leanne at the same time. Emotions are running high, anxiety is running high, and it just place. I didn't want to put it in place. It was or not, but at that time, I don't know.
But when we go in tomorrow, we're going to make sure there's not one of them in place. And
what else did we do, Patrick?
About the lung transplant. Yeah.
And I tell you how I would go about it if I was you. Obviously, you need to start mentioning it. Do you know if the same team that looked after him in ICU is now also in charge in
No.
that different
No.
team?
Yeah.
Do you know, is this a palliative care team? Do you know?
No, but we can find out.
Yeah. No, it is because he was the one that mentioned to Dad in our absence this morning. It was a palliative care team because he was the one that mentioned to Dad this morning that if these steroids don't kick in by Sunday, you're going to start deteriorating, and we will start giving you end-of-life medication to make you more comfortable. So that to me says the doctor is a palliative care team.
Okay, so here is what if they're starting to talk about giving you medication that makes him more comfortable, they would be talking about medications such as morphine, fentanyl, midazolam. Now, the minute he gets those medications, his cognition will start to deteriorate. And then he will be less and less cognizant about what's going on around him. That, in my eyes, could be perceived as euthanasia. Do you know what I mean with euthanasia?
Yeah.
Right. And euthanasia is still illegal, even though it's happening every day in ICU. It's happening every day in ICU. It is still illegal. Just no one wants to call them out on it.
Yeah.
How do we stop that from happening? I did mention to my sister today that someone needs to be a power of attorney.
Is there a power of attorney?
I was mentioning that with my sister today, but she didn't really want to go into that again because we were all upset and
yeah.
But that's something that we do.
The minute they start giving him morphine, midazolam, whatever that makes him more drowsy, right? You will see your dad literally fading away in front of your very eyes, and there's nothing you can do because they're pumping him full of the stuff that will hasten death. It will hasten death, right? One of the main side effects of morphine, in particular morphine fentanyl, one of the main side effects is it stops or inhibits your natural respiratory drive. Now, your dad is already respiratory compromised. The minute they give him morphine or fentanyl or midazolam, he will basically stop breathing. Right? You absolutely need to put a stop to that. I also believe you need to explain to your dad that he needs to refuse or reject those medications.
Yeah.
Right? Because at the moment you can still have coherent conversations with your dad. The minute they start giving him this stuff, it'll stop.
Yeah.
Hey, Patrick, I'm just got a pen here. Can you just write them medications down again for me, please?
Yeah. Morphine. And I'll put it here in the chat pad. Can you see the chat pad here? Yeah, well, you can. I know you can. Midazolam. I'll just put that. Can you see what I just typed in there? Can you see that?
I can't. No.
Okay. So morphine.
Yeah.
Fentanyl.
Yeah.
And midazolam. It's
right.
spelled MIDAZOLAM. In the ICU world, especially morphine and midazolam are often referred to as M&M. And fentanyl, you spell FENTANYL.
YL. Okay.
Right.
Okay.
I think you are really, really at crossroads here, where you need to act very quickly. Now, two more things. When it comes to the decision making around lung transplants, it's not ICU, generally speaking, it's the respiratory team, right? Has the respiratory team been involved in all of this?
Yeah.
Or has it mainly been ICU?
Mainly been ICU.
Mainly
They
been
haven't put
ICU.
it to the respiratory team that much because he's on that much high oxygen. It's still ICU concern. It was at the time, but now because they've moved into the ward, basically putting him on end of life. It hasn't been mentioned.
Okay. Here is another thing that I would recommend you do. Let's just say everything that you're trying to do is falling on deaf ears. I would send an email if I was you to hospital executive, right? You can find them online and you know they would have a generic sort of NHS email address. And another thing that I would do, again, if it's all falling on deaf ears, is to speak to your local MP, Member of Parliament.
Yeah.
That's what I would do as well. But most importantly, because you want your dad being coherent, you need to reject any medications that they want to give to basically hasten death, because he doesn't have a lot of reserves respiratory wise.
So is it an option for me dad to if he stays off the then things that you just mentioned and he's capable of breathing with the high flow oxygen in the ICU, how long is he allowed to stay like that for?
Well, look, I wouldn't put any timelines on it at the moment. You know, how long can a patient stay in ICU? It always comes back to that question. Patients can stay in ICU for a long time, right? And especially your dad has his wits about him. So he's not, you know, I mean, you would have seen him in an induced coma. The question is always, well, how long can you keep someone in an induced coma? That time to a degree is limited. Then patients need a tracheostomy and, you know, that's sort of a different path. But in your dad's situation, I actually think he has way more time than other patients because he's still awake. Well, let's keep him awake.
Yeah, definitely.
The minute.
Sorry to interrupt you, Patrick. I feel like it's not the information that's fallen on deaf ears. We feel like we don't know our sort of rights with dad. It's like they're brainwashing him. We don't know what we're capable of saying. Hang on a minute. Or as I say, I knew the DNR needed to be put in place. I knew he needs a power of attorney with my dad saying that the doctors are coming and seeing him today saying, you know, if these don't work, we're putting you on this medication and you're going to lose all your function. So we need to know that we're able to give it to you. So basically they're asking me dad's permission today, this morning when we were there, to give him this medication. If these steroids don't work till Sunday, to the point where dad thinks on Sunday, if the steroids don't kick in, that's me. And we don't know our rights. We don't know what, you know, is my dad allowed to stay on there? You know, we don't want to seem like, we don't know. We just don't know. We're just not wise.
Exactly. And, you know, and who's to say if they don't work by Sunday, they would work by Tuesday? You know, I mean, where's that coming from?
Yeah, exactly. Yeah.
You know, and it really sounds to me like they psychologically manipulate him by basically putting in his head, well, if the steroids don't work by Sunday, your best option is palliative care and the you know, death. That's what it sounds like to me. They're trying to prepare him for mentally.
Yeah, definitely.
Yeah, they are, and he's had a tough couple of weeks. The first coma he come out of, we were all there. The second coma, he went, I don't want to do that again, but I'll do it again for you. But I don't want everyone there. And the second coma sort of traumatized him. It got in his brain a bit more. He was more emotional. He was more traumatized by the whole experience. So he's pretty vulnerable right now. And he's being strong for us. But at the same time, he's vulnerable, and he's got loads of people around him saying all different things, and he doesn't know what to believe anymore. and it's such a shame.
Yeah, no, I think unfortunately you don't have a lot of time here to advocate what you need to advocate for, and explain to your dad that the minute they give him morphine, fentanyl, midazolam, he'll go
No
down
coming
the
back.
drain.
Yeah, there's no
He'll
coming
die.
back. Yeah.
He'll die.
Once that happens, there's no coming back from it.
No coming back.
Yeah. So
There's no
so even though this, we'll just have to tell Dad tomorrow, even though the steroids mightn't work till Sunday, you're gonna have to just stay on this machine.
Yeah, because Tracy, as Patrick's just said, who's not going to say they're not going to work Tuesday, Thursday? You know, give them a chance. If he's been that severely ill, isn't that just common sense to give him time?
I'll tell you another thing, because I do need to wrap this up in a couple of minutes. I'll tell you
Yeah.
another thing. So I have seen over the years in ICU, you have a patient like your dad coming into ICU with similar conditions. And I have seen some patients being fast-tracked for a lung transplant. I have, right?
Yeah.
They go on the top of the list because their prognosis is so poor, right? And
Yeah.
because they are already in ICU, they are in a good environment that if a donor lung becomes available, they are in a good environment to have that transplant straight away. But this requires, for someone to push him at the top of the list. Now, we
Yeah.
don't know who else is waiting, of course.
Yeah.
We don't know how urgent it is for other patients to get a lung transplant. It's a bit of a lottery, unfortunately, but he is in the right environment to have this
Definitely.
happen now.
Yeah.
If a set of donor lungs becomes available.
Yeah. Oh, Patrick, thank you so much for your time. I appreciate it. I really do.
No, it's
For all
only
your
a pleasure.
advice, and
It's
I'll be
only a
putting it
pleasure.
all in action
You
tomorrow.
know what you need to do. I do believe, given that you don't have a lot of time, I do believe you need to get in fairly hard.
Yeah, definitely.
Because they are already playing hardball. For them, they've written him off.
Yeah.
I think you need to go in fairly hard there without
Holding
to
back.
get the best outcome.
Yeah, definitely. Thank you so much, Patrick, for your time.
It's a pleasure. It's a pleasure. Thank you for coming on.
I'll speak to you soon, hopefully.
Okay,
Good
take
news.
care.
Thanks,
Take care.
bye.
Thank you.
Bye.
Bye. Bye. All right. Thank you so much, Tracy and Leanne. And I'm very sorry to hear, but you got to fight a good fight here for your dad. Now, I'm going to wrap this up here. So if you want one-on-one consulting, or if you want to become a member with intensivecarehotline.com, we have a membership for families of critically ill patients in intensive care. Go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I also talk to doctors and nurses directly. And if you need intensive care at home, please go to intensive care at home at intensivecareathome.com. I do need to wrap this up now. Thank you so much for watching. Like the video, subscribe to my YouTube channel, comment below, and share the video with your friends and families. And I'll be back for another YouTube Live next week at the same time. Take care for now. Thank you.